Hi, Dr. Garima here again, and finally we reach on the 12th SBQ, the last question for Mock 3. A very common question for Australian Dental Council Part 1 written exam. I'm directly diving into the question. I have short time to just finish this video and run for my clinic. For all the new candidates who are watching this, this is how a question appears in your written exam part 1, and I'm here just trying to guide you how to solve the questions, as you have limited amount of time and you're supposed to solve them fast and quick, and the questions are mostly tricky. They are literally a trap, and the passing percentage is less. The exam fee is high, so if you are going to give the exam, you better be prepared. So anyways, now this topic is basically the red and white lesions in the oral cavity, and of course, as a dental graduate, I mean, it wasn't one of my favorite topics. No, it wasn't, because almost all the lesions had similar presentations, so it was quite confusing, and you had to literally remember so many features of each lesion and so many exclusive features of each of them. And the worst part was it was just theoretical, because see, it's unlike your cavity preparations, class 1, 2, 3, 4 and 5. You study it and you go and practically perform it, so your brain kind of gets a better hang of it, right? And you feel more confident in it. But with red and white lesions, you study and you study, but you rarely get to see it practically, like in that 1 month of radiology posting and just 1 month of oral pathology posting, you barely get to see anything. Like maybe you will spot Lichen planus, like I remember seeing Lichen planus, etc., but not like so many of the other common ones which are stated in the textbook as common, but I could not find that in my college patients. Mostly in India specifically, you have more of tobacco based patients, so you have more of mucosal fibrosis kind of thing, and tobacco chemical burn lesions. Autoimmune diseases are very rare, I feel. In India they are there, I'm not saying they are not there, but compared to the other Western countries, I think the prevalence of them is pretty less, though our population is huge. So anyways, so hence, because it was a lot of theory and less of practical for this, yeah, it wasn't one of my favorite subjects. So but of course you are going to be presented with this in your own clinical practice, and so in any exam of ADC you will definitely find 2 or 3 questions from the oral medicine radiology book, specifically on lichen planus, systemic lupus erythematosus, discoid lupus, pemphigus, pemphigoid, Sjogren's, then other couple of other autoimmune diseases, and you will be asked to identify, and various other questions will be asked about that. So you have to be thorough, so you cannot skip that topic. You have to read. If you're bored, go to slideshare.net and download a good presentation, and just go through it again and again so that it refreshes your memory. So anyways, let's tackle one of the questions here. A 55-year-old Afro-Caribbean woman presents to you with a complaint of the sore mouth. Okay. The patient first noticed a burning sensation just 3 months ago. So she's 55. She started noticing a burning sensation. Does not mean the lesion wasn't present before that. Okay. It can be present, but it started showing symptoms like 3 months ago. She notes that the soreness is brought on particularly when she eats sour and mildly spicy foods. Okay, she had noticed that the white patches on her lips started around the same time, that's 3 months ago, and she thinks these patches are spreading. She has never smoked and consumes less than 5 units of alcohol a week. This is an important history because it rules out nicotine. The mouth is well lubricated with saliva, so basically she doesn't have a dry mouth, and the patient has good oral hygiene, so cavities etc are not there. She's not taking any medications, so it's not like, so this line, she's not taking any medication, is a very good statement, because a lot of lichenoid or lichenoid, whatever you pronounce it as, these reactions occur as an adverse reaction to some systemic medications. See, each line given in the question is very important. It's either presenting you with a feature or it's excluding a lot of features, thereby letting you go to a proper diagnosis. So don't think that okay, she's not taking any medicine. Why is this being stated here? Very important, because that means it cannot be a lichenoid reaction. The oral cavity is healthy, the caries is less, or probably she doesn't have any fillings. So again, the probability of lichenoid reaction is way less. Then it has to be something other which is developing from the body. You understand? Now, if the same question I would have said, patient's presents with multiple amalgam fillings, and since the last amalgam filling, he's noticing a similar kind of patches and the burning sensation, etc., then you will start thinking, okay, maybe the reaction started after the amalgam filling was done, so maybe the amalgam is causing the reaction. Now, can it be lichenoid? Yes, it can be. Or if I further twist the question and say the patient had a lot of amalgam fillings but never had any issue, and recently they started a medication on, say, diabetes or hypertension, and then the white patches appeared. Well, yes, it can. And now I give you the option as lichenoid, and I also give the option of Greenspan syndrome. Now, in the Greenspan syndrome, it's a triad of lichen planus, hypertension, and diabetes, I guess. So you see how I twist the same question in different ways by adding and subtracting certain features, and the clinical picture still remains the same, but my answer differs now. So when I'm reading out this question, you should immediately start, thinking of the lateral questions that can be asked. One good idea to study would be from the options which we will go through for this question, and each option that is mentioned, take it as a new topic and study that individually, because another question can be made on that, on which that can be an answer. Okay. So I hope you get an idea as to how questions can be asked and why each word is very important. So anyways, here for me the keywords are: she's not taking any medicine, she's not smoking, she's taking less alcohol, and specifically burning sensation, and it's a bilateral patch. Okay, it's happening on the both sides. So some lesions which are bilateral, my focus will be more on that to rule out other lesions, correct? Now, depending on the case presentation only, like basically no further investigations, no biopsies, etc., what is the most common diagnosis of this condition? Now, what is my keyword here? Most. Hundred and thousands and lakhs of time I have said whenever the question says most common diagnosis, meaning all the options will be correct, all of them. You just have to choose the most common. This is not a wrong or a right question. You have to choose the most common. It's like me asking you how many friends you have and which is your favorite friend. Understand? So it's not like nothing wrong or right. You just have to choose your favorite, the most common. So depending on the case presentation only. Okay, let's see the options. Lichen planus, lupus, a lichenoid, and any one of them. Any one of them technically can be right, but that is not most common. I have to pick something a little more specific. Now, if I would be confused, I would be confused between lichen planus and lichenoid, because lupus is having a lot of systemic manifestations also, and here the question is not mentioning any systemic problems. For lupus, the oral manifestations are there, but systemic is more prominent, and then the oral kind of starts. So I'm just gonna remove lupus, though it can also be correct when I'm removing lupus based on the clinical presentation only. Lichen and lichenoid drug reaction. You see, when I was reading the question, I was stressing on no medications, no previous history of fillings. So that's why I'm going to rule out lichenoid, and my answer would be lichen planus. If the same question was the lesion started after amalgam fillings was done, or after patient started consuming some systemic medications, I would have jumped onto lichenoid drug reaction. You understand? So yeah, my answer here would be lichen planus. Now, which statement is wrong? Now this is a right and wrong question. The flexor surface of the wrist and the extensor surface of the shins are common site for skin lesions. The appearance of skin lesions of SLE are same as those of lichen planus. Oral lesions of lichen planus or lichenoid reactions may persist for many years and often are resistant to medications. I think I have to just go this further. Often resistant to treatment, therefore ask about previous rashes. Great. Okay, now you saw the answer here. I was going to tell you all that. Anyways, so the answer here is the appearance of skin lesions of SLE are same as that of lichen planus. No, they are not. Systemic lupus has a classic butterfly shaped rash. So I have opened here lupus, and it has like distinct 11 characteristics, but the most common is a butterfly shaped lesion, especially around the nose and the cheek area. That is a classic sign for lupus. Lichen planus doesn't have that in the skin lesions. Also, photosensitivity is one thing which is associated with SLE and not lichen planus. So we'll go to lichen planus, and if you read about the symptoms of the oral lichen planus and the skin manifestation of it, they won't have the classic butterfly shaped lesion, understood, which SLE has. So the statement of the appearance of skin lesions of SLE are same as those of lichen planus are wrong. The appearance of oral lesions of SLE and of lichen planus can be the same. See, oral mucosa is a very limited area, and whatever appear can be red and white lesions. That's why the term red and white lesions. But the skin lesions have different manifestations. Skin is a huge organ. It's the largest organ in the body, right? And the way it reacts and distinguishes helps you in diagnosing certain lesions is the presentation of it. So lichen planus will probably appear again as rashes, but SLE will have a distinct butterfly shape, photosensitivity, and I want you all to go through the 11 criteria for lupus and remember it. Very important, not only from the exam point of view, but from a clinical perspective also. If you get a patient and perhaps you would be the person who would be diagnosing, like initial probable diagnosis and referring the patient to the physician. It happens a lot of time, you know. The starting manifestation starts in the oral cavity and you spot it even though they are not symptoms, because probably the patient came for a checkup, and then you start asking, you know what, I see a rash or I see some lesions in your mouth. Do you have any presentation on your skin? And the patient remembers, oh yeah, I think my skin is developing in so and so area, and then you just have a look and you are like, this doesn't look normal, let me refer him to the physician. The physician diagnoses it as something else, and finally the patient starts having a treatment at an early stage, you know. So unless you know, how would you diagnose? So very important for you to read through all the symptoms. As boring as it may sound, go through it. Okay? You have the skills, you have the power to treat. And like Spider-Man movie 2 says, with great power comes great responsibility. So yeah, be responsible, read. How do you explain the darker pigmented areas? Okay, let's go to this. Okay, so this picture is somewhat similar to the exam picture. You can never get the same exam picture because of course they will not give us the pictures. So imagine there was a little hyperpigmented areas here, basically darker areas. So the question is saying, what are those? They are basically post-inflammatory reaction. Do you remember the histologic slide of lichen planus? We used those HNE pencils, remember those? Hematoxylin and eosine pencils, like so expensive pencils. I thought, I mean, I used to think when I was in my it was costing us 50 rupees per pencil, and I used to find it very expensive. Now this is like 2007, okay, and yeah, and those pencils used to break so easily, you know, and so many people used to just take your pencil away if you were not watching over it. So you had to literally hide it in your bag. So anyways, that purple pencil, we used to make dots of it. That is the inflammatory cells, right? So lichen planus is nothing but an inflammatory reaction, and the hyperpigmented areas are post-inflammatory reaction pigmentation, basically. So what are the hyperpigmented areas? They are basically post-inflammatory pigmentation, nothing else. They are just post-inflammatory pigmentation. Now coming on to next question. Which condition is most frequent in females and there is higher prevalence in patients of Afro-Caribbean ethnicity? So the answer here is lupus. Because it's documented, it's not something I'm making up. because more frequent in females and higher prevalence in patients of Afro-Caribbean ethnicity. The answer in the textbook is lupus. That's why I'm going with this answer. So even though this question is based more on lichen planus, like I mentioned, you should read through all the options, because on any option, any question can be made. See, remember, always in exam, it is not necessary that whatever scenario is given to you, all the sub questions will be based on that scenario. Any sub questions, like example, the sub question 4 can be just a basic dental question out of the blue, not related to the scenario. So do not confine your mind on the scenario and then answer all the sub questions based on that scenario. They may just put in one question like this. Now this question I can ask in any sub question. It has got nothing to be related to this scenario. You understand? So many people make silly mistakes because they think, okay, this is based on this scenario. No, the keywords of the questions have changed. They are just trapping you by directing you in that direction. No, don't be deflected at all. And that requires practice, solving the past paper questions. Only reading theory is not going to help you. It's like you have learned very nicely the parts of the car. You know what is a gear, what is an accelerator, what is a brake. But unless you actually are driving on the road, you won't be confident enough to measure your speed and turns unless you practice it, no matter how much you know well in the theory. You understand my point? So only when you start practicing, your brain will start to realize, okay, this sub question is not related to the scenario, I should rethink my answer. You understand? Now, which statement is wrong about the management of lichen planus? Which statement is wrong? Relieve symptoms because the underlying disease process is not easily influenced without the use of drugs that have significant adverse effects. Okay. Many patients with lichen planus have no symptoms and therefore do not require any active treatment. Okay. Gingival lichen planus is aggravated by plaque, and in some patients maintaining optimal oral hygiene can be difficult because of pain. That is true. Some patients find the detergent sodium lauryl sulfate in certain, this option was certain culprit to initiate the lesion.